Alex, I have a quick question. When it's on the share mode, I can't see like the chat box or anything like that. Is it just, can I only see it when I exit share?
Yeah, exactly right.
Okay, just so I know
yeah.
for questions to make sure to end.
Perfect.
Okay.
Okay, let's get started. Hey, everybody. My name is Alex Pond with the UNM Division of Community Behavioral Health at the University of New Mexico. Welcome to today's webinar presentation for the Law and Mental Health webinar didactic series. Just a few things before we get started. I just shared the ACCME link in the chat. For those interested in continuing medical education credits, please use that link now. For those interested in APA, CE, or Certificate of Completion, I'll share a chat with 5 minutes left in the presentation. In order to receive credit, you must attend the full presentation. Today's recording will be available in about 1 week. We will also be uploading the PDF to our Google Drive of the PowerPoint for you to reference at a later time. I will now introduce you to Dr. Viljoen. Dr. Viljoen is a clinical psychologist working in private practice, specializing in forensic psychology. She is also a co-founder and clinical co-director of the Second Judicial Court Clinic. Her professional work has included delivery of training and workshops in law and mental health related topics to various agencies. Dr. Viljoen is also affiliated with the University of New Mexico, where she is an adjunct instructor in the psychology department and a clinical assistant professor in the psychiatry department. In these roles, she supervises the clinical work of postdoctoral students and teaches undergraduate courses in Introduction to Forensic Psychology and Alcohol Use Disorders. She has co-authored a book chapter and several publications related to violence risk assessment and management, in particular, the use of protective factors in these assessments, gender issues in forensic psychology, and diagnostic issues in personality disorder. She has also presented over 45 conference presentations on topics related to mental health and psychology and the law. Dr. Viljoen, we're very excited to have you. Thank you for taking the time to speak with us today. And I will now hand it over to you.
Thank you, Alex. It's kind of interesting being on this side of things. I'm usually the one doing the introduction, so it's a little bit of a shift for me today. So I just wanted to mention that today's talk is going to be actually based on a chapter that I did write about strengths and protective factors in violence risk assessment, which I've shared with Alex to provide to everybody here today. So I think that'll be uploaded to the Google Drive link that you guys get to get the recording. So you'll be able to get a copy of the chapter for those of you that are interested. Okay, so I want to just dive on in. So we've already gone over this. To get your CE credits, you got to click on the link towards the end. Just a couple, boilerplate disclosures. I don't have any financial benefits or conflicts to report. And then, of course, the views that are expressed in this presentation are those of mine and do not necessarily represent the University of New Mexico. All right. Okay. So first, I just want to go over what the learning objectives are for today's talk. So there's just 3 learning objectives. I hope that the attendees after today will be able to explain what protective factors are and their utility in risk assessments and management. I want them to be able to name the most widely used strength-based violent risk assessment measures. And I'm going to actually be presenting both adult and juvenile measures as well. And then also finally discuss how the assessments of protective factors may enhance case formulation, planning, and risk communication. Okay, so I'm sure many people that are here on this talk today are very familiar with the idea of risk assessment. I'm sure there's even potentially some people attending today that are much better experts on this topic than I am. But I wanted to just give like a little bit of a kind of crash course reminder or overview on risk assessment in general. So we think of these as 3 different types. There's unstructured clinical judgment, that's basically based on the experience and knowledge of the individual doing the assessment, typically a psychiatrist or psychologist, and they're often unstructured. So, the person will do the interview in any way that they choose and use whatever information they choose to form their opinions. The next type is actuarials. So this is using statistically derived items to come up with a probability estimate for future negative outcomes, such as violence, for example, or sexual violence. Usually the focus is a little bit more on the prediction side of things than the risk management side of things. So we're trying to come up with an accurate prediction of future risk, essentially. The next type is structured professional judgment, or often referred to as SPJ. This is basically using items that are derived from empirical literature combined with clinical judgment. So it's sort of like trying to combine that unstructured clinical judgment method with the actuarial method in a way, because we're using empirically based items, or sometimes they're called like checklists that help us to inform our clinical judgment. So we're considering items that have been found in the literature to be related to violence risk, like someone's violence risk, essentially, and then using our own clinical judgment in each individual case to come up with a likelihood of future negative outcomes. The idea is that for SPJ approach, the focus is a little bit more on that risk management piece rather than the prediction piece. Of course, we are trying to gauge what someone's risk is, but the idea is really to focus on trying to identify areas that we could focus our management of that individual to ultimately reduce their risk of future violence. So just some risks, some weaknesses for each type, right? So weaknesses for unstructured clinical judgment, as I'm sure everybody here today is aware, unstructured clinical judgment is just not good, okay? It's basically as good as flipping a coin. Sometimes it's actually even worse than that. So we know that this is not the ideal way to assess someone's violence risk. It's subjective, it's very, very susceptible to bias, and also it's not systematic. So we can't really even be consistent with ourselves, right? Sometimes you might interview somebody and you're asking certain questions because that's what's coming up for that person, but then you forget to ask other questions because you're not using a systemized or structured method of doing the evaluation. Weaknesses for actuarials is that it's a nomothetic approach, right? So it doesn't include individual factors. So we're looking at just global risk assessment or global risk factors that have been derived from research, but we are not able to really think about an individual, like the idiographic part, like the one potential risk factor for this person that really makes a big difference isn't going to be considered because it wasn't included in that big group's analysis essentially that was used to derive those actuarial items. It's also mostly static risk factors. So there are some actuarial measures that do include some dynamic factors, but typically they're mostly looking at static risk factors, which are problematic because static means they don't change, right? So how can someone's risk in theory reduce when the risk measures being used are basically static items, right? So, someone's gender is not likely to change. Their history of violence or their history of criminality is not likely to change. It's only likely to potentially become worse. Or even if someone doesn't become worse, it's still going to have the same history, right? We can't change the past. So it's not looking at a more recent or what we refer to as dynamic risk factors. Another potential weakness or area that is particularly relevant for today's talk is that most actuarials will exclude protective factors or strengths. So they're largely risk focused, right? So looking at the risk factors that are present for an individual and don't really consider protective factors in any kind of systematic way. So that's another area that is a weakness for actuarials. And then weaknesses for SPJ is, of course, we're still using clinical judgment, so it's going to be susceptible to clinician bias, right? So for those of you that were at Tess Neal's presentation, it was either last week or the week before, I can't remember exactly, right? She presented that typically actuarials are the most reliable because they don't have that susceptibility to biases. So that's clearly the major weakness for SPJs. But as I said, for today's presentation, the real kind of focus is going to be on that weakness for actuarials excluding protective factors. And it's not only that actuarials are the only ones that exclude protective factors. Structured professional judgment tools, also typically the ones that have been developed, typically exclude protective factors as well. But there have been measures that have been developed that use the structured professional judgment model that are for protective factors. So they typically work together with other structured professional judgment tools to essentially supplement or address that issue. Okay, so I get this question a lot. So this is a particular area of interest. I started being interested in protective factors, gosh, back in during my master's, which I actually completed in the Netherlands. I did my master's at the University of Maastricht. And when I was thinking about what my master's thesis was going to be and sort of what topic I wanted to look at, I started becoming really interested in the idea of using strengths and protective factors in violence risk assessment. I'd always been interested in violence risk assessment, but I liked the idea of looking at resilience in individuals and how we can utilize their strengths and their protective factors to not only make outcomes better for that individual, but also to improve the quality and accuracy of our violence risk assessments. So I've been sort of thinking about this idea, working on this idea for, I guess now that would be almost 10 years. God, time goes so fast when you're having fun. So it's been quite a number of years that I've been thinking about this. But when I do these presentations or when I do trainings on certain structured professional judgment tools that use protective factors, a question that I come up with a lot is, why use strengths? We're already doing this, right? A lot of people will tell me that they're already thinking about protective factors, and I totally agree, and I think that is something that we all already are doing. But just like that unstructured clinical judgment, right? We talked about earlier in the 3 different types of risk assessment. When we do unstructured violence risk assessments, we're not as reliable because we're not as structured. We're not including items that we know have been empirically supported to be related to future violence risk. The same can be said for protective factors, right? It can be helpful to have something more structured and based on the evidence and based on research to inform our violence risk assessment. So that's one of the main reasons I would say, but there's a number of other reasons that I'm going to be going through, right? So as I've already mentioned, we've basically had a predominantly risk or weakness focused approach, both in research and clinical practice. This goes beyond just the violence risk assessment procedures or practice, right? Even in just clinical practice, when we're doing an assessment on somebody, when we're looking at all of those criteria for mental health concerns, our focus is on those deficits or risks or weaknesses, right? But there's been a kind of a outcry or a notice or within the clinical literature that we need to be considering protective factors and strengths, right? And so now, for those of you that are in the clinical field, that this is a requirement, right? We have to consider and include strengths and protective factors in our clinical assessments. And so that has been now an influence in the forensic field as well, where there has been certain scholars and individuals that have been saying that we need to include strengths and protective factors in our forensic assessments as well. There's also influence from things like the Good Lives model, right, which is a focus on strengths and therapeutic alliance, holistic tailored therapy, essentially trying to improve an individual's skills so that they can live a better life, right? So that's, I think, a very big influence on why we should be using protective factors and strengths in our violence risk assessments. I really love this quote. This is from Turnell and Edwards. It's a rather old quote, but I think it really kind of speaks to the sentiment of this issue, right? So they lamented that the fact that focusing solely on risk factors is rather like mapping only the darkest valleys and gloomiest hollows of particular territory, right? When you focus on the negative, you're really missing a lot of positive things about an individual. So another reason is that, the way that, for example, Hart and Logan in 2011, they said that risk assessments should inform risk management, not just predict future offending, right? Prediction is less useful. What I think is more helpful and why we want these assessments or why the courts want these assessments or, parole boards or inpatient review boards, those kinds of groups and entities require a risk assessment for an individual in order to best assess their needs and also make decisions about their freedom, essentially, right? So we're trying to decide, can this person be managed in a less stringent area or a lower level of care, for example, right? Can we discharge this individual from the hospital to outpatient care with, outpatient management? Can an individual be released from prison and be appropriately managed in the community in parole with parole services, right? So the idea is not just to say this person's going to offend with 68% likelihood in the future. The idea is to say, what are the person's particular weaknesses and what are the needs that this person needs to have addressed in order to be successful? And part of that equation is looking at what strengths somebody has that we can build on, or what protective factors someone has that is reducing their risk or is likely to help them be successful in the community, right? So it's a shift of our perspective. It's a shift of the way we think about things. We're not so much focusing on, the risk the person has, but we're also thinking about what strengths they are, what strengths they contain within themselves or their context or their community that can help them be successful, right? So the next step really from that risk management piece is to say that risk management should do more than just reduce or eliminate risk. It should also build and develop new protective factors. So we should be building on people's strengths that they already have. And then we should also be trying to help individuals gain additional strengths or protective factors. So ultimately, I think that risk assessments that don't include strengths are biased in terms of overestimating the risks and weaknesses that an individual has. I think it also can lead to stigmatization, right? So we're really focusing on these things that people lack or their weaknesses or their downfalls, essentially the negative qualities for an individual. And so that can create stigmatization, or it can also even create a negative therapeutic alliance, especially if you're working in like a clinical setting, like a hospital, where you're going to be doing feedback with the person on their risk assessment, where when you include strengths or protective factors, there's actually research that shows that there is incremental predictive validity. So it does actually have a better prediction of future risk when you include strengths or protective factors. It can also provide hope for clients. And this is what I really find helpful, right? Because not only for clients, but when you're submitting a report to the courts, you're providing your referral source a more holistic picture of an individual. And you're not just saying, basically, there's no hope for this person. They have all of these bad things in their life, and you should basically lock them away and throw away the key, right? You're saying, yeah, they have all these bad things, but they've also shown resilience, or they've also got these protective factors, or they've also got these strengths that we can utilize and build on to help this person in the future, basically. So it can provide hope for the clients. It can also provide hope for, like I said, the judges or people that are reading these, that the person's not a lost cause, right? And we know from research, if you think about the research that was done with the children, right, in schools, when teachers are told that somebody, a student is less intelligent or bad, whether that's true or not, that individual gets treated differently. And that actually does have an impact on that student or that child, how they perform in the future. And I think the same thing can happen with our criminally justice involved individuals when you have that focus on bad, negative, as opposed to having also those protective factors or strengths to balance the picture for the individual. It can also really help facilitate treatment planning, right? Because we can have some treatment goals or some focus for management that can be both positive and helpful for the individual. So what are protective factors, right? So I've been sort of on my soapbox trying to convince you all to do this. And like I said, I know that most people on this training are thinking to themselves right now, I already do this, I already think about protective factors. And I 100% know that people do. What I'm advocating for is that structured, more systematic approach to thinking about protective factors in risk assessment. So again, I just want to reiterate that I know that we're all already thinking about these things. This is just a way to do it in a more structured way. So it's helpful when you are doing something to have a uniform definition or way of talking about these things. So what are protective factors? So this is a definition that I got from the SAPROF, which the authors of the SAPROF, which is one of the measures that I'm going to be mentioning later. And it's one of the most widely used protective factors tool for violence risk assessment. And so they define a protective factor as any characteristic of a person, his or her environment or situation, which reduces risk of future, and then in brackets, sexual violence, because it can be for violence or specifically sexual violence as well. Okay, so this is another question that I get a lot. Well, aren't protective factors just the opposite of risk factors, right? Isn't it just risk factors not being present? And in some cases, yes, but in some cases, no. Okay, so in general, the approach is very different. So we're thinking about what strengths somebody has to build on. What are some positive goals that people can work towards or the treatment team can work towards for an individual? It's more about what can be built up for an individual rather than what should be broken down or removed for an individual. Okay. Also, some protective factors can be risk factors when they're not present, right? So self-control, for example, when somebody does not have self-control or lacks control, that can be considered a risk factor. Um, Whereas other protective factors generally are not risk factors when they're not present, right? They actually have nothing to do with risk factors. For example, leisure activities or an intimate relationship, or sometimes like religion can be considered a protective factor for certain individuals, but lacking religion does not mean that that's a risk factor, right? So they're not always just the opposite or the lack thereof. Another question that has been very interesting to me and something that I've kind of been thinking about through my research on this topic and trying to see, how protective factors work. And this is something that we're still, I think, looking at in the literature. We don't have a lot of research that actually addresses this issue of how exactly protective factors work. But generally, we think of them as either promotive or protective, right? And so I don't think it's an either or situation. I think that it's both, right? So promotive basically means that certain things are effective for everybody, right? So it's a promotive effect for some factors. So certain things are going to just be promotive for success, essentially for everybody who has them. And then some factors are going to be protective, right? So they only moderate when risk is present. So if you think about the idea of resilience, right? So resiliency is when someone is exposed to a negative outcome or a risk factor that should lead to a negative outcome, but they show resilience when they don't get that outcome, right? So this is, I think, the area of research or literature that best talks about this idea is the PTSD literature, right? So when someone is exposed to a trauma and they do not develop PTSD, we talk about that person as showing resilience, right? And so we look at what factors those individuals have that help them to not develop that negative outcome. So when I was thinking about this and doing research on this, I relied a lot on the PTSD literature to help inform my thinking on resiliency when thinking about risk for violence, right? So individuals have these risk factors, they get exposed to these negative things that are likely to increase their risk for future violence or offending, but they don't offend or they don't reoffend, right? So what are the factors in that person's life or in that person's, context or their environment that prevents them from reoffending or prevents them from engaging in that outcome, that negative outcome, despite the fact that they have all these risk factors. And so that's when we talk about a factor as being protective, because it is moderating that person's risk when present. So another way to think about it is sort of like a scale that's balancing, right? And so this is a sort of a simplistic way to think about it, because I want to be really clear that because we don't know a whole lot about how protective factors work, it's not a matter of just more protective factors than risk factors, but that could be part of it, right? So it could be that somebody just has more risks than they have protective factors, and then that's why they end up being arrested again or getting in trouble again or engaging in violence again, right? It could also be that somebody has one protective factor that is so influential for the person that despite the fact that they have 6 risk factors present, but they've got this one protective factor. For example, I can think of a couple cases that I've even had myself with individuals where, like a woman who was potentially high risk for future violence, she had a baby and that changed everything for her. She became so focused on wanting to be a good mother and not wanting to repeat her generational trauma that she really focused on getting her treatment on track, taking her medications. She took classes for parenting, so for her, becoming a mother, having that baby was such a huge protective factor for her that it helped her to be successful in the future, despite the fact that she had this long list of risk factors in her life, right? So I think that it can work in a number of different ways. And I think that's, if there's any graduate students on this talk today, that's an area of, I think that is surely lacking in the research and the literature that would be really interesting to look at. So a way to look at that would be the measures that I'm going to be talking about, trying to see if there are certain items that are more predictive than others, right? If it is a matter of just counting up the protective factors and there's more versus less risk factors, and kind of exploring those issues, because I think that's an area that is very interesting to be able to understand, are certain things more protective than others, or is it a matter of just having more protective factors than risk factors, or is it a combination of those two things? So that's just something that I've been really interested in. And I think that there is some research that is coming out recently, kind of looking at those things, particularly looking at which items are more predictive than others, for example. Okay, so I want to just kind of mention some measures that exist. This is a real brief overview. I don't have enough time to really go over each measure in any kind of depth. I may not even include all measures that exist. I think many people that do violence risk assessments know that the violence risk assessment tool, like industry, so to speak, has really just exploded exponentially. I think back in the 90s, there was like, a handful of these measures. And I think the last time I heard there was something like 137, or I can't remember exactly the number, but it was in the hundreds, violence risk assessment tools that existed. Now, protective factors tools are certainly much less prevalent and frequent because, as I mentioned before, the focus has always been on risk, right? So they're not that many, but it is possible that there's been one that's been developed recently that I'm not aware of. So I'm not saying that this is a all-inclusive list, but these are sort of the tools or the measures that are the most researched or the most widely known about or the most widely used. So I start with youth measures because the youth field or area or literature research area has been thinking about strengths and protective factors long before the adults did, okay? So I don't know if it's got something to do with the population being so young that people are already looking at them through a more positive lens, right? We always want to have hope for youth for their future, whereas perhaps with adults, there's sort of this idea of like, well, it's too late now kind of deal, which I think is a mistake and incorrect, which is why I do research on this and why I'm a proponent of using strengths and protective factors. But for whatever reason, individuals who have been working on violence risk assessments, measures, and research with youth populations have always been thinking about strengths and protective factors. We talk about measures for youth as first generation and second generation because the first generation tools that were started to be developed in the 1990s for youth already included some items, but they weren't as comprehensive or comprehensive is the best way to put it, right? So for example, they only included a handful of protective factors that were sort of like yes or no, present, not present type thing. Like for example, I think the savory has six protective factors. So the tools are still largely risk focused or risk based, but they do include some protective factors for consideration. So both the savory and the YLS-CMI both have some protective factors included, but they're still predominantly risk focused. But it's still notable and different to the adult measures because most adult measures were completely void of any protective factors or strengths. After the first generation, then the second generation of youth measures starts to come about in like the sort of 2014, 2010 kind of time frame, right? So a good 20 years after the first generation. We have the short-term assessment of risk and treatability adolescent version. And then there's also the SAPROF youth version, so the structured assessment of protective factors for violence risk youth version. And I should mention that the second generation tools both developed after the adult measures, right? So both of those tools have adult measure versions that were developed first. And so a lot of the research and the knowledge that was gained from developing those adult versions were then applied to and adapted to youth population, of course, incorporating and consideration of the broad youth literature. So this is just a little table. It's kind of busy, but it's something that I put together that kind of outlines the different things that you would want to know about these measures, right? So like how many items, how is it scored? Is it an SPJ or an actuarial? What is the reliability and validity of these measures? I'm not going to go into this too much, but I think it's just helpful because, you know, as a forensic evaluator, when I'm deciding what tool to use in my practice, I want to know these things so that I can talk about them in testimony, right? So that's from my perspective. You know, a researcher would also want to know these things to be able to compare and contrast to potentially new measures. Those kinds of questions come up, right? So as I mentioned, that's six items. So I think I said six, but the Savory has 6 protective items. The YLS/CMI has 7 protective items, whereas the SAPROF youth version is all protective items, 16 only protection items. They have no risk items on the measure. And that's because it's intended to be used with a risk tool. And so for youth, the SAPROF is typically used with either the Savory or the YLS. So it's used in conjunction with one of those measures. Typically it's used with the Savory because the Savory is also an SPJ. And so, you know, those two methods or models work better together than using an SPJ with an actuarial. But I've also seen people use the SAPROF with the YLS. So it's not to say that you can't combine an actuarial with an SPJ measure. People, you know, do it in clinical practice all the time, even though the authors may turn over in their graves if they heard that, or, you know, be outraged. But it is something that happens quite often in clinical practice. The START AV is 24 items that actually have both strengths and vulnerabilities. The START, if you're not familiar with it, the adult and the youth version, is a little different to other measures because it has 24 items that are both rated as strengths and vulnerabilities. So they're the exact same item that is actually rated both as a strengths and vulnerability. So for example, I think there's an item that's called like finances, for example, or yeah, I think there's a financial management item that you can rate that person both on their strengths for that item and also their vulnerabilities on that item. There's other items like relationships, right? And so you can say whether that's an item for that person is a strength or a vulnerability, but you can do both. So it's actually possible for somebody to get high protection or high strength and high vulnerability on an item because you're rating over a period of time. It's usually about 2 weeks in the past, right? So you could look at somebody's actions or behavior or their functioning for the past 2 weeks, and they could actually show potentially within that time frame, you know, some serious vulnerabilities on an item. But then the next week, maybe they change their medications. Now they're actually showing some strengths in that area. And so it's actually possible for an individual to be rated as maximum strength and maximum vulnerability on the same item, which I think also speaks to that question before of isn't protective factors just the opposite of risk factors? And the answer is no, especially if you think about within the context of the START, which is basically the items can be both, right? The way that they're scored is also listed in here, right? So typically for SPJ, it can be a little different, but ultimately you typically rate low, moderate, high, right? So whether the person's got low, moderate, high risk or low, moderate, high protection. Then actuarials are usually like a 0-1, like present, not present, you know, the score typically. The SAPROF does actually have zeros and ones for rating each item, but ultimately you come up with what is called an overall protection rating, right? So The SAPROF has had multiple different methods or modalities for the rating scale. So they've done the low, moderate, high, and then over the years they've adjusted to low, moderate, so low, low, moderate, 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 high, and then high. So they found that clinicians like that because there's a little bit of hesitancy to say just low or just moderate, right? Sometimes you have somebody, you're just more comfortable saying low, moderate, or maybe they're a little bit more risky than moderate, so you want to say moderate high, but you're not quite wanting to say that the person's completely high. So, and I think there's even some research with the SAPROF that shows that 5 point, I think it's 5 different points, can actually improve reliability and validity as well. So that's the way that the SAPROF is typically rated. And as I said, it's usually rated protection, and then it's combined with a risk measure to come up with an ultimate opinion that combines the risk and protection, which I'll talk about in a second. And then the START is this low, moderate, high, and you rate separately for strengths and vulnerabilities. So you rate the strengths as low, moderate, high, and then you rate the vulnerability as low, moderate, or high, and then again, you combine them. And so you can see that the first generation AUCs are a little bit lower than the second generation. So 0.64 for AUC means for the SABRE and the YLS. And then the SAPROF and the START are both in that 73 to 80 range. So the strengths are 73 and then vulnerabilities are 70 to 80. Typically they're reliable, the intercorrelation coefficient. So, how reliable, if I rate it and you rate it, are we going to come up with the same ratings essentially, right? So usually we see, 80s to 90s. The only one that was a little bit lower was the YLS, has a range of 61 to 85. So they're usually considered pretty reliable, good intra-rater reliability, I should say. Okay, so adult measures. So for this one, for adults, I have to mention the risk-based measures first, because there aren't measures like the juveniles or youth measures that have both strengths and vulnerabilities combined in that first generation, right? So the HCR20, the VRAG, and the COVR are 3 widely used sort of first generation risk assessment tools that of course have gone, through updates and redevelopment, right? Like we're on the 3rd version of the HCR20, for example. But these measures were first developed to evaluate adults' future violence risk. And then there was this realization that we're missing a big piece of the equation for individuals, right? So it's like we only have one side of a coin when we're looking at risks only. There's that other side of the coin is protective factors. And so in reaction or in response to this, measures were developed that focused on strengths or protective factors. And so usually, like I said, the SAPROF, for example, the idea is to use those measures in conjunction with the risk-based measures. So that's why for adults, you have to mention these risk-based measures because they're typically used in conjunction with the strengths-based measures. So here are some strengths-based measures. And I should say typically because there are some measures that do include both risks and protective factors. And I'll talk about that in a second. Like I believe that the irons actually is a measure that is similar to the LSM or CMI. So because it has both risks and protective factors included. It's also a self-report measure, so it's a little different to the other measures that we've been talking about, which are essentially rated by a clinician or use clinical judgment as opposed to a self-report measure. The dynamic risk assessment for offender reentry is another tool that looks at protective factors. And then the SAPROF and the START are 2 SPJ measures that provide completely protection. So let me step back a little bit. So the SAPROF is only protective factors, just like the youth version, right? So the adult version is only protective factors. And then the START is, again, those 20 items, because the adult version has 20 items, whereas the juvenile has 24. It has those 20 items that are simultaneously rated as both strengths and vulnerabilities. So here's a little bit more that same sort of table for the adult measures. So the irons has 130 items, of which 26 are protective factors. It's a self-report measure, like I mentioned, that people just rate true or false on the items. It's considered an actuarial tool. There are those 4 indexes. So the SRI is the static risk index. The DNI is the dynamic needs index. And then the PSI is the protective strengths index. And then the ORI is the overall risk index. Okay, so you can see there's the predictive ranges for those. And then there's the reliability. So there's an alpha reliability scores over there that range basically from 60s to 90s. The DRAO, the drawer, I think is how it's usually referred to, has 19 items, of which 6 are protective. So that's a little bit like the Savory, where it's like mostly risk items, but there are also protective items included. And it's rated on a 0, 1, 2. It's SPJ measure as well. And there's the stable index, which is basically like static items, essentially. Acute index, which is more like those dynamic or current or recent items. And then there's the protective index, which has the protective items basically. And so you can see the different AUC scores for those there, and then it shows good reliability. Then we have the START, which, like I mentioned before, has 20 items that are all rated on a strengths and both as strengths and vulnerabilities simultaneously. And then one of the things that I haven't mentioned yet that's an important distinction between the START and the SAPROF is that the START is typically, in addition to the START also being all-encompassing because it includes the vulnerabilities in it. And so you don't need to use an HDR 20 or something like that with it to rate it. What's more differentiating really is the time frame that you're evaluating for. So the START is for short-term risk. That's right in the name, right? So you're looking at something like 2 weeks to a month in the future, right? It doesn't have much value or use further in the future than that. So it was designed to be more short-term or acute risk. So like, for example, within the hospital, right? So you're trying to think of what privileges somebody can have, you know, now for the next 2 weeks. So it's looking at more like current risk, essentially, which is why the START actually doesn't include any static or historical items. The 20 items are all dynamic items. They're all current, frequently changing items. Whereas the SAPROF is used with the HCR 20 and it has more that HCR 20 time frame for risk, right? So we're thinking more like 6 months to a year, right? More long-term risk. Of course, not much longer than a year, but we're thinking more longer term risk, not so much immediate risk. So that's one of the biggest differences between the two. And they were both being developed around the same time, actually. It's really interesting. Both the authors of the START and the SAPROF were both developing their measures really at the same time and sort of like growing together, but they've always been differentiated by that time frame for violence risk. So you can see again, those are both SPJ measures. They have good AUCs, again, very comparable, right? So the SAPROF mean AUC is 0.77. The strength AUC for the START is 0.71. The mean vulnerability AUC is 0.73. Okay, so again, you're thinking about that the AUCs here are for short-term risk and the AUCs here are for longer-term risk. So that's what's being predicted. And then both show good reliability. Okay, so just keeping track of the time here. So I wanted to move on to applying these strengths to our assessments, right? So it's all well and good. What are they? What are the measures? How do we actually use them in our clinical practice? So this is the SPJ assessment model that I've adapted from the START AV. So that Viljoen is not me, it's a different person. So it's Jody Viljoen. She is the main author of the START AV. And so this was the model that's included in the manual for the START AV. And I really just liked the overall model in general. And I think that it's applicable to any assessment of violence risk. And so that's why I modified it for this talk to kind of show what I think the process should be when we're doing these evaluations, not just with strengths, but also just in general, right? So step one basically is we're gathering information. So this is sort of assessment 101. We gather information, we're talking to the patient, we're getting collateral interviews, collateral records, hospital records, things like that. The next step is once we've got all of our information, right, we have everything that we need to know, now we're going to assess strengths and vulnerabilities. And we can do that with the start by rating the different items, like the 20 for adults or the 24 for youth. Or for if you're doing, a SAPROF and HDR evaluation, what you're going to do is then you're going to rate the HDR 20 and you're going to rate and then you're going to rate the SAPROF, right? So each item on those two measures. So it just depends, what process, which tools you're using, but ultimately it's the same thing. You're assessing strengths and you're assessing risks or vulnerabilities, however you want to talk about them, by rating the items and then identifying key goals and items, or identifying critical items, right? So each measure has a different way of sort of like highlighting really important items. So for example, the start has key and critical items. And so you can mark certain items as key or critical. And so those are basically very important for that person's formulation of future risk. Whereas the SAPROF has key and goal items. And so key items would be items that are particularly protective for that individual. And then goal items would be items that you think could be really helpful for that person in the future. So they may not be there just yet, for example, employment, like the person's currently unemployed, but in the past, when they've been employed, that's been something that's been really protective for that person when they're engaged in, gainful employment, they're not breaking the law, they're not getting in trouble. It provides a meaning of life and things like that. And so you would mark that item as a goal because you want to build on that. You want to improve that for that individual, for example. So once you've rated all of your items and your measures and you kind of want to now put it all together, right? So you're going to rate your level of risk and protection. So for the start, you would basically rate your vulnerability level and then you would rate your strengths level. For the SAPROF HCR combination, you would be rating the HCR basically low, moderate, high risk. Then you would be rating the SAPROF low, moderate, high protection. And then you come up with an integrated risk or an integrated opinion, which basically combines the protective factors and the risk factors to come up with your ultimate low, moderate, or high rating, essentially. And then the fourth step, which is, I think, the most important step, is how you integrate and apply that information, right? So your formulation for the individual. What are the scenarios that you're particularly concerned of with this person? And then what are your intervention plans, right? So what are the needs for this person? What are the things that you're going to put into place to prevent violence and also help them be successful, right? And then, of course, reassess, right? And so this is it's not a one-time thing. You want to keep doing this with somebody. For those of you that work inside hospital settings, you know that risk assessments are updated yearly usually, right? So for the start, because it's short term, the start's being done every 2 weeks or every month, just depending on the type of facility. So this is an ongoing process. It's not typically a one and done. There are times, of course, like a forensic evaluator might just be a one and done situation, right? Like I get court retained to do a violence risk assessment, and so I do the evaluation, and it is just a one and done. But often these are continuing process. Okay, so I mentioned risk formulation before. What is risk formulation? So this is adapted from the article from Doyle and Logan in 2011. Basically, they defined risk formulation as producing a narrative that explains underlying mechanisms of violence and proposes hypotheses regarding action to facilitate change. Okay, so it's kind of a mouthful, but basically you want to explain why someone's been violent in the past, right? Like what are the promotive factors? What are the perpetuating factors? The predisposing factors. I'm trying to think of all the P's. There's, the HCR 20 talks about the 5 P's for formulation, right? But you want to explain why someone was violent. Then you want to explain basically your plan for preventing violence in the future or for, creating change for the individual. Okay, so kind of breaking it down a little bit more, right? So risk formulation is almost always an interplay of different factors, specifically risk and protective factors, right? So why someone has been violent previously is always a combination of the risk factors present and protective factors lacking usually, right? So it's not just the presence of risk factors, but also the absence of specific protective factors. And so it's important when we're doing our risk formulation to be able to identify both of those things. Not only what risks were present for the person, but also what protective factors should have been there, or if those protective factors were there, this person's actions might have been different, basically. And so if you want to think about it like that, it's like if we can provide those protective factors, or if we can help that person develop those strengths, perhaps we can have a different outcome in the future, right? So for example, lack of social skills or self-control, the absence of a support network, or the non-adherence to prescription medications, right? Those are all examples of protective factors that could be missing for somebody, that if you provided those, or if those were present, their risk would be reduced. So this has got a lot of information on it, and a lot of you probably recognize this. This is typically, scenario planning that's recommended in most SPJ tools, but definitely like the HCR20v3 has these different factors as part of its within the manual to help facilitate scenario planning, which is also an important part of violence risk assessment, right? So that you want to think about the nature, right? What kind of risk, what kind of violence, the severity. So how serious is the act going to be? Are we talking about somebody who's going to threaten violence or cuss at somebody on the unit? Or are we talking about someone who's going to actually cause like physical harm, right? Who are the potential victims, right? It could be just anybody. Is it typically within the context of an interpersonal relationship? Random people on the streets, there are nurses on the unit, who are the victims likely to be? Then you want to think about the likelihood, right? So how likely is this to be, right? Is a person highly likely to cuss at their nurse and low likely to actually, strike them, right? So you want to think about the likelihood. Then you want to think about imminence. How soon is this going to occur? Are we talking like tomorrow, or is this something that's potentially down the road, 6 months from now? The next one would be risk enhancing factors. So what factors may lead to risk, right? So these are things like events, occurrences, or circumstances that actually increase someone's risk. So those are obviously going to be risk factors, right? Then what's really important for today's talk is the risk reducing factors. So part of your scenario planning, you're required to consider risk reducing factors. What are things that could prevent risk, right? So typically these are going to be protective factors or strengths, right? So anything that reduces someone's risk is considered a protective factor. So right here, you can see that it's important to know what someone's potential protection and strengths are, because you're going to need them for your scenario planning. You're going to need to know what risk reducing factors are present for an individual, right? So the same thing, it's what events, occurrences, or circumstances decrease someone's risk. Then you want to put it all together and come up with your final risk judgment, right? So I mentioned this before in a previous slide that had this sort of general process for evaluations. So you're going to rate your risk measure, you're going to rate your protective measure. Sometimes both of those things are the same measure, like the START, like I said. And then you're going to come up with your final integrated risk rating, which includes both strengths and protective factors. And I just wanted to throw this out there. There's actually research that shows that risk judgments that have integrated both protective factor scales and risk factor scales have actually shown to have better prediction than each scale on its own. Okay, so there's some citations there, but there is some research that's looked at the risk ratings for just protection, just risk, and then the integrated risk ratings to see if there is incremental validity or if there's improved predictive validity. And there's research supporting that actually integrated risk ratings are more predictive or better predictive than each on their own. So then the next step really is the ultimate goal of violence risk assessment, or at least in my opinion, but also within the literature, there are a lot of others that agree with me that this is the ultimate point really for risk assessment is risk management. So the goal is to try to integrate your findings for the treatment and risk management plan, right? So to help individuals have a different outcome, basically, right? So to reduce someone's risk by providing them with some scaffolding, some structures, some things that they can do to basically keep their risk low or to reduce their risk and to increase their success or desistance in the community. So failing to incorporate strengths at this stage may lead to pessimism among clinicians and also could result in unnecessary lengthy interventions or incarcerations or excessive supervision, right? So we want to be thinking about the R&R model, right? The risk needs responsivity model, which I'm sure many individuals, if not most, on this training will be aware of, right? We want to tailor our management strategies for individuals to their risk, right? So someone that's low risk, we don't want to be giving them a whole bunch of supervision and things and, you know, hoops to jump through, right? Because that can actually have a counterintuitive response or a criminogenic response where we've put the burden too much on an individual. And so they actually have the opposite result, right? So in line with the risk needs responsivity model, we want to be thinking about strengths and protective factors for an individual to help tailor or better suit their treatment goals or treatment plan for the individual. Okay, so UNM has this really great slide that includes, if any of you have presented for us, we always have like our, you know, our template slides, and there's always a cultural consideration slide. And I love that because, you know, I think it's really important to be thinking about this. And in theory, right, we can say that the SPJ strengths-based measures can be helpful with different cultures because they could be tailored to the individual, right? So you could potentially even add an item that is relevant for that culture if you know about the culture, right? It's like the certain Native American traditions or things like that, that, you know, if I'm doing an evaluation with a Native American individual, I could add a particular protection or strengths-based item to, you know, whatever tool I'm using, because there's usually an option like other, or, you know, you can add usually things that are particularly relevant for an individual with SPJ measures, less so with actuarials, but with SPJ measures, you can typically add something that is uniquely relevant for an individual. However, what I will say is that there's really very little research. So again, grad students out there, if you're listening, this is an area that would be certainly very important research to do, and we don't have a lot of information about this. You know, so there was a recent literature review that was done by Wanamaker, Jones, and Brown in 2018, and they remarked that there is really not enough to say whether this is helpful for different cultural groups. They also mentioned that gender is an area that is underdeveloped. I've done some research on that, and there are some differences for females and males with the strengths-based tools. I'm not going to get into that because that's potentially a talk on its own. But I just wanted to throw that out there that, you know, just because it's in theory could be helpful, we really don't know because there hasn't been that much research done. So we kind of, it's a big old question mark. And so that's why I said, if there's any grad students out there, this is an area that I think would be really, really important research to do. And there is some stuff that's coming out, but we just don't know enough yet to say whether this, whether this is helpful for different cultures. And largely because it's possible that other cultures could have different protective factors, right, that are not identified on our tools because the tools are based on largely, you know, Western or Caucasian populations. Okay, so I am miraculously doing well on time. I tend to, I'm infamous for going way over time and taking too long on these things. So I'm quite proud of myself because I only had a couple slides left and I've got 2 minutes. So I'm doing really well. What I want to leave you with is sort of the clinical implications, right? Like, so for me, it's the so what question, right? It's the so what slide. Like, okay, you told me all this stuff, so what? Like, why is this important? So for me, the use of strengths or protective factors in violence risk assessment is important because it improves prediction of future adverse events. It also provides clinical practitioners with evidence-based tools that can help predict future success, not just future failure, right? It also helps kind of plan for interventions, you know, in a better, more well-rounded way, right? So like the last point says, basically helps clinical practitioners with intervention and management planning by identifying gaps in services, supports the person needs and skills, as well as avenues for fostering success, right? So it's sort of, like I said, shifting your perspective, right? So instead of, and I'm going to say this anyways, because in grad school we used to talk about shit-colored glasses, right? Instead of rose-colored glasses, when we're really focusing on the risk, we're just wearing shit-colored glasses. We're only caring about someone's bad things, right? So this is more, and I wouldn't say this is a rose-colored glasses approach. I think it's more of a realistic approach because we're integrating both of those negatives and positives together to provide a more realistic picture of an individual. It can also improve the therapeutic alliance. And this is what I think is really important, something that I've also noticed in my own practice. I don't always have the opportunity to do feedback with individuals that I evaluate, but I have had some options or opportunities to do that in certain contexts. And I find that when I do an evaluation using strengths or strengths-based tools or strengths-based measures, that feedback session is so much more useful and productive than when you're only doing risk items, right? Or just risk tools, because you're able to give the person some hope or give them something positive in your feedback session as well, right? So it's sort of like that, what do they call it, a compliment sandwich, when you like tell them something good, tell them something bad that they need to work on, and then you finish it with something good, right? You're actually able to do that when you are systematically evaluating protection or strengths for an individual. It can also be a good way of structuring clinical team discussions. It can create that uniform language, right? So when systems use the START, right? So when all hospitals within a certain forensic system all use the START, it creates a language that everybody understands. Everybody knows the items. They understand the outcomes, the risk ratings, things like that. And so it can create that uniform language that just makes management of individuals so much easier for continuation of care, discharge planning. Like I talked about the like levels, right? If someone needs to go on a higher level, lower level, privileges, things like that. So I think it could be really helpful in creating that facilitation for team discussions, right? So nurses, doctors, psychiatrists, psychologists, everybody can kind of come together and talk about these things in the same way. Okay, that's it. I think it's actually like 2:01, perfect. I don't think I've ever been so on time in my life. These are just some references. I'm not gonna like read through them all for you right now. They're just there and they'll be there in the slides. And if you have any problems getting any of those, yeah, you're feel free to email me. I have obviously hard copies of all of these. And then, like I said, the chapter, which is listed here somewhere. Yeah, right there, the Viljoen Nichols, that chapter, it will be included in the Google Drive that kind of summarizes all of these things for your reference. Okay, so now we're gonna do questions. And I think I can actually see them without having to end my share slides or whatever. Oops. Okay, so I'm going to be reading the questions. I'm moderating for myself today. So might give me a second to read a question first before I can answer it. Okay, so the first question says, in my jurisdiction, the state recognizes only 3 protective factors in sexually violent predator cases: age, completion of sex offender treatment, and medical issues that prevent them from engaging in sexual offenses. In my opinion, these are not empirically based protective factors. What do you think? Other than reviewing your own empirically based protective factors in our report and testimony, any suggestions on how we may approach this misconception? Great question. It's so difficult when we work within systems that aren't necessarily utilizing, empirical information in their decision making. So while age might have some protection related information for sex offenders, I don't think there actually is any research that supports age as a protective factor, and it's not included on any of the measures that I mentioned. So that one's not very helpful, I would say. I think the treatment is generally considered a protective factor, engagement in treatment, but not just treatment completion, but it's more about the engagement somebody has in treatment. So for example, in the SAPROF, when you're rating treatment, it's more about the person's engagement in treatment and the benefit they get from treatment, right? So we all know individuals that just like show up to their group, they don't say anything, they get their stamp, they leave, right? And then at the end of their time, they have their completed treatment, but they've actually gained nothing from that, right? So that's not protective enough for that individual. And then I'm sure there are certain medical issues that might be protective, right? But there's nothing that uniformly has identified that as a protective factor in totality. So I don't have super helpful advice for you. What I typically do in our jurisdiction is, even though there's something, we don't have that kind of restrictions here, but I typically will try to educate the courts anyways through my reports and testimony. So you can include protective factors and you can explain that these are protective factors that have actually been found empirically to support use for prediction of future sexual violence. Like the SAPROF has a lot of support for using it within for sex offender evaluations. So all you can do is really try to educate the courts and include that information in your reports and hope that you get some traction. But sometimes we have to appeal to our judiciary, or try to get more active in legal processes that we like, right, to try to get some statutory change. But it's hard. It's a hard thing to do for sure, and we deal with that in some other areas here in New Mexico. But it's certainly not an easy endeavor. Okay, next question. So okay, so next question says, how do you work to have the strengths assessment not be viewed from a deficit model? These are the protective factors and they don't have them. I see what you're saying. So I think just like when you're doing a risk assessment, right, you talk about the items that somebody has, not necessarily the items that they don't have, right? So you want to be highlighting what's present for the person. So when you talk about, when in my risk formulation, I will say something like, these are the risk items that were identified. They have this many historical items, they have this many clinical items, and then they have this many risk items for future offending. But then these are the strengths, so these are the protective factors that somebody has, right? And so really like highlighting the things that are present, not so much what is lacking for an individual. And so that's sort of a way to do that, to sort of focus on what's present for risks and what's present for protective factors, and not so much focusing on what's lacking. However, when it does come up sometimes is when you know that something's been present for somebody in the past, right? So protection has been present in the past, but it's not currently present. You can say that this is something that is within the person's capability, basically, right? So you still frame it as a positive, right? They've been able to do this in the past, and with support and help, they can do that in the future again. And so that's how you can kind of, for those goal items, shift that focus from deficit to a potential goal or a treatment goal. Okay, the next question. I'm confused about how to interpret when someone gets both high vulnerability and high protection scores on the same item. How does that get converted into a statement about risk? Okay, yes, great question. So that's how I was talking about the START specifically, right? And so I wish I could, what, it might be actually helpful to show you the START rating scale. I don't know if I can quickly pull it up, and then you might have to, actually I'll stop sharing, and while I'm kind of talking, I'll find the START rating scale so I can show you what I mean by it. Let me see if I can. So when you're talking about it in the risk, though, you don't necessarily focus on that one item that's both, right? And the way that it can be both for somebody is because like people can differ from day to day, right? And so the START is really about that short-term risk, and it's really about the short-term future risk. So when someone comes into a hospital right off the streets, right, typically they're very unstable. They're not on medications, things like that, right? So you can talk about how someone was really impulsive, acting out, really struggling with that, or really struggling with mental health symptoms when they first got to the hospital. And so it was a cue on vulnerabilities. However, since they've been here, they've started taking their medications. They started to really take into effect about 7 days after they've been in the hospital. And so during the second week, they've actually shown significant improvement, and they actually now are showing protection or strengths on that area because of the interventions. And so you can kind of, formulation can take those things into account, basically. And I think I was going to try to find the START rating scale so I can just pull it up and show you, because it is a lot easier to view, to understand. Okay, here. This is I'm going to share my screen really quick. This is for the juvenile one, because it's just the one that I happen to be able to find fast. Okay, so here's the START summary sheet. So you can see, I'm going to zoom in here, right? So strengths, vulnerability items. So school and work, you can see how you can rate it as a moderate, low, low, moderate, high, and then low, moderate, high, right? And then you can see if it's a critical item or if it's a key item. So that's how the rating scale looks basically. And so you can rate both. I will say that, in practice, most of the time, you're not rating both as high strength and high vulnerability. In practice, typically, if one is high, the other one's low, or potentially what happens is they both end up being moderate. Like sometimes they can show strengths in that area, but then sometimes they also show vulnerabilities. So it's not that it's a frequent occurrence that they're both rated as high, but it is technically possible. And so that's why I mentioned it. So hopefully that answered the question. Okay, next question. Can you speak a little bit about any VRA measures that can be used for things like fitness for duty or workplace risk assessments, and that have norms for those without significant psychiatric or offender histories? Great question. And I don't have a great answer. I don't think that there are actually any tools. I mean, there are some violence risk assessment measures for workplace risk assessments, but I don't know of any that have protective factors or strengths for that particular population, right? Because the measures that I've just mentioned typically are related to psychiatric or offender history populations. So I'm not actually aware of any measures for protection or strengths that specifically look at that workplace environment. So again, also grad students, if you're here, that's a great PhD project. But again, I'm not aware, and I don't typically do workplace evaluations, or not so much. So there could be one that I'm just not aware of. And if anybody does know of one, please share in the Q&A. Okay, next question. Do any of these measures assess for minimization or faking good when it comes to risk assessment, or what score ranges would indicate that someone is not being truthful about their ability to control anger, impulses, or act violently? Great question. So when it comes to structural professional judgment measures, they're not rated by the person themselves. So there isn't that necessity for faking good or like not being truthful, essentially, right? You are interviewing an individual and gaining information from them like that. So of course, during your evaluation or your interview, they could be telling you all these great things and they're wonderful, but the most important part of a risk assessment is collateral information, right? So you want to have hospital records, jail records, talk to somebody who knows them, talk to their charge nurse, the main CO on their unit, their wife, their mom, right? Because those are going to be where you're going to get some helpful information that can either corroborate or show that the individual is not being truthful with you. Because ultimately, these measures are not, like I said, self-report measures. They're based on your rating of that information using all available sources of information. Now, the self-report measure that I mentioned, the IRNS, that does have validity scales included. And so it does have like a faking good scale included in that. Okay, so next question. What are your thoughts on incorporating assessments of strengths that are outside of the standard forensic area, such as the VIA survey of character strength self-report? Yeah, I think that's a great idea, actually, and something that I'm familiar with the VIA, and I think that is another way to get some strengths for the person. The only downside potentially is that though the VIA hasn't specifically been researched or explored for prevention or prediction of violence, right? So while those are still, I think, helpful because you're still providing information about some strengths or values that the individual has, which you could use for informing, your risk management plan, right? So if you find out from the VIA that, family is very important for the person, then that could be something that you utilize to help with your treatment recommendations or your risk management recommendations. So I think it could be helpful for treatment recommendations, but it's not so much currently useful for your violence risk judgment because we don't have any research looking at that particular measure with that outcome. Okay. The next question is, what are the most common protective factors that come up in your assessments? That's a great question and not an easy one to answer because, for example, on the SAPROF, some of the protective items are actually like system provided protection things. So for example, being under supervision is considered an external protection item. And so for some people, being in probation or under supervision can be what's really protective for that person, right? Because they're having to check in, they're needing to like be monitored and things like that. And so that provides structure for the individual. But when someone is getting better and they don't need that anymore, you know, in theory, you can take that protective item away. So I don't know if there is one or certain protective factors that come up more frequently. I will say that, you know, employment is a big one, right? So having gainful employment, being engaged in something productive is a really big one that does come up quite frequently. And then also interpersonal protective factors like a really supportive, protective, not protective, pro-social interpersonal relationship, right? So of course, if a romantic relationship is toxic or unhealthy or actually results in the individual engaging in violence, that's not going to be protective for the person. But I do find that, you know, family or romantic partners that are very supportive and pro-social, that those often come up as well as really protective. Okay, so let me see. We've got a couple more questions. I'm going to just address this one because I sort of addressed it already. So the question is, are there any specific tools to assess protective factors for sexual violence? And I think I mentioned that the SAPROF has actually been validated and utilized for sex offense violence risk assessment. So the SAPROF would be one that you could use for those types of evaluations, and you would use it in conjunction with whatever sex offender risk assessment you typically use, right? So the SAPROF has always been designed to be used with a risk assessment measure. So that one I do know is specifically validated and has shown to have good research support for using with that population. Let me see. So the next question, I'm going to read it. I don't know if I can answer it, but it says, how do you suggest navigating between best practices, e.g. reviewing all records, fully completing the HCR, addressing protective factors, et cetera, and real world issues, right? Facility demands to complete risk assessments more quickly and produce short reports. That's a great question. And it's one I think that many of us deal with frequently, especially I think about the competency crisis that's occurring throughout the United States and in Canada, right, where some jurisdictions you're required to provide a dangerousness opinion. We don't here in New Mexico, but there are some jurisdictions that require you to provide that. And those evaluations are, you know, very time pressured, short. You don't have a lot of time. You frequently don't have records. You know, like here in New Mexico, we don't have access to collateral information unless the person signs an ROI, which is a whole issue that I don't want to get into. So that's a really great question. And I don't know if I have an answer, because I think we can only just do the best that we can. We make good efforts to get information that we can, right? Like do the best you can to get the jail records at minimum, try to do some kind of collateral if you can't get records. I think all you can do is to try to do the best that you can under those circumstances. So you may not be able to write as comprehensive a report as you typically would. You know, you might have to write shorter reports. You may not be able to interview all collaterals or have all records, but you got to at least try to get a minimum of each of those things, because ultimately when you provide a risk assessment opinion based on no information, right, that's just not going to be a reliable or helpful opinion. And so sometimes we have to try to advocate for ourselves and communicate to our referring source or, you know, our bosses basically, that we just can't do that with that information, because garbage in, garbage out, basically, right? And so it's just not helpful. I think that was all my questions. So thank you again for joining. I really enjoyed giving this presentation. Hopefully it was helpful. I'm always happy to answer questions. My email is on the slides. Alex can also easily provide my emails to anybody who has additional questions and would like more information.
Thank you so much, Simone. We truly appreciate you.
Sure. And hopefully I wasn't too auctioneer speed. I talk really fast, but I think I did okay this time.
It was great. Thank you.
All right. Thank you.
See ya.
See ya.
And we also have the CE link in the chat now. If people want to go grab that, if they haven't already, feel free to reach out to me directly if you have any questions regarding that.